Okay, good morning. So today we are going to talk about complications in endoscopic sinus surgery. I'm, of course, as most of you know, from Mumbai in India. Okay. So before we actually get to the issue of complications, we just spend a few moments on avoidance of complications, right? So taking a good history is primary importance, that you check for illnesses, proptosis, any difficulty in vision, any past history of medical or surgical interventions. So for example, it could have been an angioplasty, not related to the nose, but that patient will then be on aspirin or any blood thinners. So you have to be aware of these past histories and what medical treatment the patient is on at the moment. Surgical, again, important because no matter how easy it looks, revision surgery is always difficult, always 3 times more difficult than a primary surgery. So never take revision surgery easily. When you are doing radiology, a limited CT scan, coronal scan is the worst thing you can do for your patient. You must have scans in all three planes, sagittal, axial, coronal. And unless you have this along with images on DICOM, it is not possible for you to get a 3D perspective of anatomy in the nose. And if you don't have the 3D perspective, understanding anatomy and working towards the sinuses becomes more difficult. Of course, it's a good idea to do a diagnostic endoscopy because that gives you additional information which a CT scan cannot. A CT scan is shadows, it's interpretation of what you feel. But an endoscopy is actually seeing whether its soft tissue is more like a tumor, more like a polyp, is it adhesion, synechiae, is it just in contact, etc. And probably the most important aspect in all of this is to take an informed consent. Again, the emphasis is on informed. Unless you have taken an informed consent, you will always be scared to go to the skull base because you're scared of causing a CSF leak. You're scared to go to the lamina because you're scared of an orbital complication. You will never be doing a complete FESS. So the moment you take an informed consent and the patient is aware, it doesn't matter if it's an antroconal polyp. I want a full informed consent, which includes anesthesia risk, all the eye complications, bleeding, CSF leaks, everything goes in and signed on a paper. So radiology, as you mentioned already, triplanar scans. If you feel there's a suspected complication like an orbital abscess or a CSF leak, then we go in for an MRI as well. Soft tissue is good for allergic fungal sinusitis and to look for double densities. And when we look at complications today, we are going to look at the three main issues, which is bleeding, the eye, and CSF leaks, are three main primary concerns. Post-op, of course, there's a whole host of other things that you can get as in terms of complications. And though they may not be as serious as intra-op, it can add a lot to the morbidity and the recovery time of the patient. Okay, so let's start with bleeding. So bleeding starts with a good pre-op preparation. So when I get a patient of polyposis, I don't want to operate on this patient tomorrow. I want to set him up, I want to do medical treatment, I want to give steroids. I want to operate when the patient feels his best. So this patient, for example, I will give him steroids with a word that at the end of 10 days, you're going to feel superb. You're going to feel like you don't need surgery. But that's the time I want to operate because then the surgery is easiest and for you, the results are going to be better and the risk of a complication is less. And you will find that 95% of your patients will come back. So don't be in fear that the patient will go away and not come back. Prepare the patient well. Needless to say, FESS surgery is all about anatomy, so you must understand your scans well. And when you operate, you have to save mucosa. And this mucosa trauma starts from your entry point, from your inferior turbinate, from your septum, how your instruments go in. So it's little coordination, right? Prof was mentioning earlier in his lecture that that hand-eye coordination is important. It is very important because if your instruments are hitting turbinate, hitting septum, hitting mucosa, every time your scope goes in and out, it's going to get blood. You're going to get frustrated, and you're going to get more and more careless, reckless with your instruments. This also means that in the post-op period, more risk of synechiae. So use through-cut forceps or a debrider. Use sharp stuff to cut things. Maintain a good BP and pulse. For us, the product is important, so mean arterial pressure multiplied by pulse should be less than 6,000. So if my pulse is 60, my BP can be 100, mean arterial BP. Okay? If the arterial BP is 80, because you've done some hypertension, your pulse can go higher, can go to 70, 75. So it's always a product of the two. It's not only the BP that comes down. Head is up about 20, 30 degrees and slightly turned towards you, especially when you're operating on the right side. So typically when you operate on the right side, you have more risk of getting a CSF leak. On the left side, more risk of getting an orbital injury. Local versus GA, in the past we were doing a lot of surgery, and I'm talking of in the 80s, early 90s, that we were doing a lot of surgery under local anesthesia because of two things. We thought that there's a higher risk of bleeding under GA, and at that time most of our agents were inhalational, whereas in local it was definitely reduced bleeding. And two, the patient was our alarm bell. My eye is hurting, my head is hurting. So you know you're close to the eye, you know you're close to the brain. We were not that confident as surgeons. Today I will do everything under GA. Everything, nothing under local. Even a DCR will be GA, given to me the option. Just because our anesthetists are able to control the blood pressure much better, able to control pulse better, and we have switched now from inhalational mainly to IV anesthesia. So we don't get so much of vasodilation. Okay, so we generally tend to pack with cottonoids or Merocel, not roller gauze. Roller gauze is abrasive and it should be avoided in the nose. So for example, this is working towards the frontal sinus, and you see there is a lot of bleeding in this area, and it is not a good idea to continue operating when you have so much blood here. What happens is that you will put in a suction there. A suction is going to cause circumferential trauma, and in this very narrow area of the frontal recess, you're going to get synechiae and closure. So you have to get some patties in, get some hemostasis, open up the ethmoid if you need, allow the blood to drain away. So how will you do all these things, right? You're going to use adrenaline-soaked patties. And again, a word of warning, I know there are people who want to use pure adrenaline, okay? And you have seen some experts talk to you about the use of pure adrenaline. Please understand there is a difference when an expert operates and when a beginner operates. Please understand this. When an expert operates, there is minimal mucosal trauma. And so when he's using pure adrenaline, there is minimal absorption. When a beginner operates, there's a lot of mucosal trauma. And now when you try and use pure adrenaline, there's a lot more absorption. Okay, so for everyone, unless or until you become an expert, use it diluted. For me, I would use 30 ml either xylocaine usually with 4 ampules adrenaline, and we prefer xylocaine to saline because my anesthetist can then keep the patient in a slightly lighter plane because of the effect of the anesthesia. If there is a lot of bleeding, pack and change sides. You can play table tennis on the patient as long as mentally you remember at what stage you stopped and remember when you go back. That I've stopped at this stage, I need to go back. If you're not comfortable changing sides, be patient and continue. So when you operate, okay, try at least in the beginning not to have a clock in your OT. It is not important whether you can do a FESS in 15 minutes, in 1 hour or 4 hours. Okay, what is quicker? A surgery that takes 3 hours or a surgery that takes 1 hour and then requires revision surgery? It just doesn't make sense to me. So for me, that is the one time patient has invested his time with you, and I don't want to rush through that surgery. I want to make sure that this patient doesn't come back for revision, and I spend the least amount of time in post-op care because I have been gentle and careful with the mucosa. Allows open spaces. So if you have, like example, an intact bulla technique and you're doing frontal and you have blood coming towards you, open the bulla so the blood can drain posteriorly. And in very rare cases, when there's a lot of blood, you can put a catheter in the nose to drain the blood as you keep operating. In a FESS, this should never come to this stage. But if you're doing an angio, if you're doing a tumor where you can't stop, you have to keep operating because that's your best solution to stop the bleeding, then you can do that. You can use monopolar insulated suctions anywhere in the nose except on the skull base. On the skull base, always bipolar. Okay? At any time, if you can't see clearly, surgery must stop. By far, the commonest reason for any complication is lack of vision because of bleeding. So if you have bleeding in your field, arrest the bleeding. If you can't, pack the nose, get out, come back another day. Okay, so let's talk about some arterial bleedings. Our main vessels, anterior posterior ethmoid, sphenopalatine, branches, carotid artery. Okay, so let's look at anterior ethmoid by itself is not a big vessel, is not a scary vessel. Our fear of the anterior ethmoid is only because of the possibility of retraction into the orbit. And then it forms an hematoma in a closed cavity, puts pressure on the nerve, and then you can get blindness. So that's our fear, right? By itself, the artery itself is not a big artery. It's easy to control, easy to cauterize. And if you have polyps, and I get a bleed in the anterior ethmoid, so you can see that this vessel is bleeding, right? There's a puncture in the vessel. This is not going to retract. I don't have to panic. I don't have to get scared. I can take my time, I can look at it, assess it, I can put a small patty, I can get my bipolars ready, cauterize it, surgery will continue. Okay? So a little bit of patty in there, and then you can get a bipolar in. If you have a second person, it's good. Otherwise, you can use a suction bipolar, so that gives you vision and also takes the smoke away. And once it's bipolar, then you can continue with surgery. So for me, sometimes even if I have an exposed anterior ethmoid at the end of surgery, I will intentionally bipolar and cut it. Because in the post-op period, I'm doing cleaning, I have forgotten that there's an exposed bare artery. I don't want to cut it then, right? So it's nothing, and it's not an artery to be scared of, as long as you're gentle and it doesn't retract. Posterior ethmoid artery is not very common in this particular patient because usually it's flush with the skull base. In this patient, we were doing a CSF repair and I had to scrape the mucosa off around that area, and so we got a bleed here. Now this is a little more posterior, it's a little more difficult to get, and so initially when I was trying to bipolar it, I was finding it wasn't I wasn't able to get the exact spot because by the time my instrument went there, it was already bleeding again. So we did get a third hand in, we got somebody to do suction, to be able to localize exactly where the bleeding is from and then cauterize it. Right, so if you have a suction bipolar, it's easy, but otherwise get the help of one more person and then cauterize it. From there we go to the posterior. So this is when you go lateral and posterior from the maxilla. If you want to go like ½ centimeter from the posterior maxillary wall, you can get this lateral branch of the sphenopalatine, which you need to cauterize. So I've tried to show you different ways of dealing with hemostasis. We had bipolar, we had a second-hand bipolar, we have a unipolar probe here, and you just cauterize it because now here you're nowhere near skull base. Sphenopalatine branches, you're okay. Again, sphenopalatine vessel here, you can use a insulated suction and cauterize it. No big deal here. It's easy with one hand especially. Cavernous sinus, again, so this would happen generally when you're doing transsphenoid surgery, for example, a pituitary. And it depends on at what stage of the surgery there is bleeding. So in this patient, the bleeding happened at the start of surgery. Now, when it happens at the start of surgery, if I put Surgicel and gel foam, it blocks my view. I can't see further. I can't go on and do a pituitary. So I use Surgiflow or Flow Seal. And this is very good material because it stops the bleeding and then you wash away the excess and you can continue with the surgery. So it gives you vision. If it's at the end of surgery, I won't waste money on Flow Seal. I'll just put Surgiflow or Surgicel or gel foam. And it's not difficult to control cavernous sinus bleeding. Okay? Cavernous sinus bleeding is venous bleeding. It's not very difficult. Bipolar you can do if it's small, especially in this area, because you have two edges of dura between which is the sinus bleed. You have to get these two edges of dura together and then coagulate it. If you try and do one edge, you're going to increase the bleeding. So be a little careful when you're doing bipolar. The dragon is a little different, right? The ICA is different. It's completely different. So this is a clival chordoma we were doing. And at one stage we thought we were just taking a little bit of that tumor off. And just behind it was the ICA, a little more medial than we had thought. And this is a little puncture in the ICA. And you'll see how in one moment the picture changes to red. Nothing you can see, right? With a puncture. Again, fortunately, it's a two-surgeon, four-hand technique. So you have an additional person. The first thing you need to do is to localize where the bleeding is. Second thing is the first thing actually tell the anesthetist, you've got a carotid. So they are infusing fluid, right? They're pushing in fluids. You don't want the BP to drop. You want to maintain blood pressure. They need to get someone to get for the blood, ask for blood. 3-4 bottles, whatever. And then you localize. So you see there's no panic. I can see where the bleeding is from. 2 suctions to triangulate where the point of bleeding is. Once you've located it, you don't need to put 1 kilometer of roller gauze pack into the nose. We have used a small patty. That's it. Just right pressure at the right spot is adequate if you know what you're doing, where you're doing. Right? What works best in this situation for a carotid bleed? Anyone? What works best to control carotid bleeding? Muscle, right? Crushed muscle is magic in this area. So we keep the pressure on. Somebody is getting, the thigh is already exposed anyway for these kind of surgeries. Somebody is taking out muscle. This was during actually live surgery. We were at a workshop demonstrating surgery. So we already had flow seal ready. Somebody in the audience suggested we try and use flow seal. But you see that movement of that patty for a second. And the blood starts again. The person taking muscle was not so experienced, so he was taking a little time. So we said, okay, we'll try the flow seal. So that's the flow seal that went in. You have to take out the patty for that. And when you put flow seal for an arterial bleeding as against a cavernous sinus bleeding, it's completely different. It takes like 1 second for the flow seal to get washed off. Nothing, there's no chance. So you have to get back to that muscle, keep the pressure on. Sorry, this thing is little unedited, so go a little forward. So finally we managed to get some little muscle in there. And then it calls for a little bit of dexterity. So the neurosurgeon who was with me has to move the patty, push the muscle, move the patty, push the muscle, put the patty back on it. And all this time I have to try and maintain vision because the blood is spurting and rebounding off different walls towards me. But at the end, once you get a good muscle in position, you hold it there for 5 minutes. You can put another small piece of patty on top of it. And then at the end of 5 minutes, you can take out your patty. And if it's not a very, very big tear, like in this case, you see that there's no bleeding. We were able to put a little bit of tissue glue on top of it. Normally, at this stage, your surgery should stop because there's every possibility of a pseudoaneurysm happening now, maybe a week later, maybe a month later, and you will repeat angiographies on table a week later, a month later for an assumed aneurysm, okay, and deal with it. For us was different because we had in the workshop, we knew nobody else is going to complete this surgery, so we continued. But otherwise, you would stop it. So even for ICA, remember, it's easy for me to say right now because we've been through these, but do not panic. Panic is your worst enemy. Localize, pressure, anesthetist, blood, maintain. And then if you feel you don't have muscle or you don't know how to do it, just put a lot of patty packing on top of that little bit of patty initial. That initial patty or small pack is important to get precise localization. If you put a big pack, sometimes it doesn't put pressure there and it keeps bleeding under it. Okay. So I'm just going to take you through a little video now for you to understand the eye before we talk of complications of the eye. Okay. So this is of course a cadaver dissection. So We now have a 360-degree approach to the eye, and we can do what is called an eyelid approach to approach lesions which are superior or lateral to the optic nerve. So we can go in, elevate mucoperiosteum of the bone, and then you come to the superior orbital fissure. And if you go medial to the superior orbital fissure, you come to the optic nerve. So all pathology superior lateral, I would go in from there. Okay, so that's your nose. Now in the nose, we have already done an ethmoidectomy. We've opened the sphenoid. So at the back, you see the carotid artery. All this is the orbit. Okay, ethmoidectomy is done. And this probe was coming in from the outside. So let's go and continue from the inside. So when you look at the eye from the inside, okay, this is the frontal recess. This is the anterior ethmoid artery. This is all skull base. Okay, this is the sphenoid sinus. This is lamina papyracea. Are we clear on this? Okay. So we're just taking off the bone here. So mucosa is gone, bone is gone, and that's your little nipple for the artery, which again, when you're going intra-orbital, you have to cut the artery because otherwise it gets stretched and tears. So it's better to cauterize it and cut it off so that you can then push the orbit or translocate the orbit. So we just cut that anterior ethmoid artery off. So again, important to note this. Medial rectus, have removed the fat. Mucosa gone, bone gone, fat gone. Medial rectus, superior oblique muscle. And your artery comes out between these two. Okay? So now you see the anterior ethmoid artery comes always between medial rectus, superior oblique, and then continues in the skull base. If you're lost and you want to see it on the scan, look for medial and superior oblique muscles. Okay, so if we follow that artery back in, we see the ophthalmic artery. If we follow the ophthalmic artery back, you'll see the posterior ethmoid bifurcation, right? So that's the posterior ethmoid now coming into your view. And when we follow that further back, of course, you'll see it coming off the internal carotid. Inferiorly, you have the inferior rectus and the medial rectus, and this is your usual corridor when you're dealing with pathology in the orbit, okay? And if you go further in through all of this, then only you will see the optic nerve, and in this case you are seeing the third cranial nerve. Okay, so you're seeing, let me just move that muscle back. So you're seeing the optic nerve here, and you're seeing the branches of the oculomotor here. So this is superior orbital fissure. This is optic nerve. Now you see the amount I've gone through to reach the optic nerve. So to damage optic nerve in the globe is very difficult, right? You have to go through mucosa, bone, periosteum, fat, muscle, and only then you get there. You see also that these branches of the third nerve, the lower branches, will supply the muscles in the infero-posterior aspect. So that gives the oculoplastic guys the advantage of cutting the muscle anteriorly, for example strabismus, and then suturing it out without loss of movement. It's only if you damage muscle in the posterior part that you lose the movement. Okay, so optic nerve, third nerve and its branches, going to the inferior rectus, the medial rectus. That's the entire optic nerve at the back. And we can follow it back here. Okay, so that's the carotid artery. And the carotid, let's go back here. So this is ciliary ganglion as it comes off from the superior oblique fissure and all the different branches of the third nerve. Okay, so this is just to give you an idea of what the orbit is, how to do orbital surgery, and if you have a complication, what you have done to get to that point. Okay, right, that's the fourth cranial nerve supplying superior oblique. We'll go a little quicker here. And that's the end of that ophthalmic artery as it would have come off from the carotid artery. So carotid artery ophthalmic, it goes around the optic nerve inferolaterally. So when you're doing an optic nerve decompression, you want to be in the upper half, not in the lower half, because sometimes the artery may come a little more superior as compared to going away straight laterally. So if that's the optic nerve and this is carotid, it tends to go lateral and inferior, but sometimes it may come a little bit up and then go in. So if you're doing an optic nerve decompression, if you want to cut the sheath, on the right side you're going to go above 9 o'clock, on the left side you're going to go above 9 o'clock, and here above 3 o'clock. Clear? In the superior part. Okay, so How do you damage or cause orbital issues? Uncinectomy in the past we used to do with a sickle knife, and sometimes with a very narrow infundibulum. You went through the uncinate, through the infundibulum, through the periosteum, and you got fat in your field. But that was anterior, and in the anterior aspect, it doesn't matter really too much if you expose fat. The only problem is it comes in your way. What do you do with fat exposure? Put your debrider away first of all. Let's not get more fat out. Don't try and suck the fat or clear the fat or cut the fat. Just put a small periosteum, put a small Surgicel over it and continue. While operating, always keep the eye open so you can ballot the eye, what was called then the Stankovic sign, to check if you got eye in the nose. If it does happen, you tell the patient not to blow the nose so that you don't get subacute emphysema, and 3-4 days of little bruising, and the patient is okay. Keep an eye on the vision, eye pressure movements, just in case there's bleeding. But usually there's no problem. So this was the patient where I was using not a sickle but a periosteum for the uncinectomy. And I went through all of it, bone, periosteum, everything, and got fat exposure straight away. Right, so we are doing a Stankovics, confirming that it's fat. And this was a little tricky because this was a patient with a mucormycosis, and I had just opened the orbit for the entry. So I put a small piece of Surgicel over it to just protect it, and then continued the surgery. And you can see that at the end of surgery, even in the post-op period, so that's just the Surgicel covering it, it looks all right, it heals well. The maxilla, of course, is bare because it was a fungus patient. Another example of how you can get orbital fat. So we are doing a FESS. Again, this patient had right sinus, though it's not so obvious on the scans because you've treated the patient, but there was bilateral facial pains. So we did a backbiter, uncinectomy, put in a probe, went inferomedially, and I couldn't feel myself in the maxillary sinus. So then I tried with a suction to see if I can get in. Couldn't get in, but what I did get, you see, is fat. Right, I got fat. Now this is as anterior as possible, as inferior as possible, and still fat. So what did I do wrong? I didn't look at the scans close enough. Okay, so when I went posteriorly, you see, I walked into the maxilla. So when I look anteriorly at the uncinate, you see the uncinate here, and you see how close the orbit is to the inferior turbinate. So this is where I went in, very anterior, and I hit the orbit. The moment I went a little posterior, the orbit walked away from me, and I could get into the maxilla easier. So if you're not sure, if you're not comfortable, if you're not getting maxilla straight away, go posterior, go inferior. You'll be safer. Okay, so what happens if you get anterior ethmoid damage and you get bleeding? You're looking for vision, proptosis, eye movements. First thing that goes, color vision. Then regular vision. Eye starts swelling, becoming tense before it actually becomes proptotic. And your eye movements start getting affected. If this happens on table, just do an endoscopic medial decompression. If it happens in the recovery room, first thing to do is to remove the nasal packs. Allow the patient to bleed from the nose, and I can take the patient back into theatre and do the same thing. If there is a half bleeder that sort of doesn't allow you to see properly with the endoscope, but is still causing proptosis, I would then do a Lynch incision and do an external decompression from here. Okay? And unfortunately, the youngsters over here are not exposed so much to transfacial surgery, but it's an equally important part. So when you get chance to do onco surgeries or other things, learn external surgeries. A lateral canthotomy is the last resort. It is not the treatment for an anterior ethmoid bleed. It is only something that helps you buy time. So if it's in the ward, you don't have an OT available, doing a lateral canthotomy gives you that extra 1 hour just to decompress the eye and prevent vision failure. Okay, and gives you that 1 hour to take the patient. You still have to take the patient into theatre and do an orbital decompression. Still have to. And a little bit of massage in the beginning also can help. For muscle, you've seen on the cadaver that we have gone through cartilage, you've gone through mucosa, bone, periosteum, fat, and then muscle. So anterior, you have a thicker pad of fat, more difficult. Posteriorly, thinner pad of fat, easier to cause medial rectus. So posterior orbit, be careful of your muscles. Optic nerve, be careful in your optic canal, especially if it is dehiscent and in the presence of disease. So the sphenoid is full of pathology. Then you need to be careful, especially if you're using a thing. Onodi cells, if you have not recognized clearly on your scans, can be confused with the sphenoid, and then again you can have these problems. Any of these more serious orbital complications, get help. Get an oculoplastic or an ophthalmic surgeon to give their opinion, start steroids, and show the patient that there is concern, that we are not doing or running away from this situation, and we are trying to deal with it as much as possible, right? So this is an example of an orbital trauma. So you've got periosteum fat, and there's a big hematoma now, intraconal, right where the muscles are. So we should not have this sort of situation. So we come to our last major complication, which is CSF rhinorias. Again, importance, check the scan. It's not necessary for your cribriform plates to be bilaterally symmetrical. One can be type 3, one can be type 1. So look at each area separately, stay away from middle turbinate attachment. Commonest site of injury is the lateral lamella of the middle turbinate. On the skull base, best to come from posterior to anterior, because the posterior ethmoid skull base is very easy to define. Anterior ethmoid, many more cells, more difficult to define. So work in a downward direction if you're going from anterior, upward direction if you're coming from posterior. Don't use sharp instruments, don't use sharp curettes on the skull base. Use a ring curette, use a broader curette or a blunt suction to feel the skull base. In situations where you can have skull base or bone erosion, such as extensive polyposis, allergic fungus, tumors, you need to then have more care, and especially in revision surgery. When do you suspect a CSF leak? Typically, you get a clear fluid stream in a pool of blood. So there's been blood and suddenly you see a water running through it. It can sometimes happen from mucus or serous discharge, but that will stop. That's limited. CSF leak will not stop, it will continue. What you have to do, clear this area around it, get hemostasis. Without hemostasis, you will never be able to see where your CSF leak is from. And then locate the site of leak and repair it. This is the best time to do that. If you want to run away from the CSF leak, at the time of surgery, there is a possibility it will heal because it's a traumatic leak. But if it doesn't, and you come back 5 days later, 6 days later, because now the patient's packs are out and he's leaking, and you go back, there's a lot of edema, there's a lot of crusting, and it's very difficult now to locate and repair this leak. Okay, so examples. So we were doing this surgery and suddenly we see in this little bit of blood, we see this little water sort of thing. So I'm a little alarmed, I'm a little worried about what is happening here. And though I'm in the frontal sinus, I just want to be sure that it's mucus and not CSF. So I will go in, I'll open up the frontal a little more. I will see that there was a little pocket in there where there was a small cystic polyp, and that had sort of released this water. Now I can sleep a little better. I'm not worried about this patient. But other examples, right? This was in the very early days. We had, I don't even remember, 25 years ago, debrider burrs had just come into the market, and we were excited to use them. Of course, lost control completely while doing a concha bullosa. We went and hit the cribriform plate, and we got a CSF leak. So what we did for this patient, fortunately, she had a big concha bullosa, and I had removed the whole lateral half in an intact fashion. So I could use just the mucoperiosteum of the concha bullosa to repair it. So we put a little bit of plug into it, which we took from the floor of the nose, and it doesn't have to be fat. Any connective tissue will work. So we can then avoid that extra incision. We just plug that defect, and then I use the mucoperiosteum from the concha bullosa to layer that area. So very much like you saw yesterday, we just went in, covered it, and then we could put it into position. Okay. So do the repair at the same time. Another patient, again we had finished all the surgery, polyposis, We were opening posterior ethmoid. In those days, again 20 years ago, we were using this different technique of going into the ground lamella, putting a forceps in and then driving to try and open up the bone. And once that forceps came out, there was a gush of CSF. Unfortunately for me, this was a minister of the state. Fortunately for me, I had spent half an hour with him explaining all possible complications. His daughter was a doctor. I had spent half an hour with her individually explaining all possible complications. So we of course, we had to do a formal repair here. So here we opened his thigh once we cleared. So again, don't stop surgery here. I still had to go and finish the polyposis surgery. I still had to finish the ethmoidectomy and finish everything else, right? So I finished the surgery. Then I did a formal repair. I took fat from the thigh, plugged it. This is lateral cribriform, your commonest area. And then we put in fascia as well. Okay, so we put in fascia on top of it. At the end of surgery, I told them, I've got a CSF leak. You're going to have to stay in the hospital 4 days more than what we had planned for. His only question to me in the post-op period the next day was, Doctor, how will it affect me? I like to do gym and all. Can I do exercise? I said, yeah, you already had a weak area. Now I made it strong. So after 6 months, you can do whatever you want. And he didn't trouble me at all. Because we had been clear about the informed consent. Because we had been honest with him at the end of surgery. We were not hiding. And all the medical legal cases you see against doctors are because doctors have not revealed to the patient at the time of the complication what has happened. And some other person has told them that happened at that surgery. So be clear-cut and honest with your patients. Whatever complication, put it down in paper. Put it down on your notes. If I'm doing revision surgery, you've done the primary, you've had a CSF leak, you've not revealed it to me, I'm going to be in trouble when I do that revision surgery. I'm going to open that area. So do your colleagues a favor and put it down on paper. It's safer that way than not having done it. A third patient of all these are my patients. We had a patient of malignant melanoma diagnosed post-op. The onco surgeon told us go back and clear the whole ethmoid and do a little bit of a medial maxillectomy. There is no other option for me. So while doing that, again, we exposed, just while using curette, ring curette, we exposed the cribriform and got a bit of a leak. So again, this patient, we did a proper repair, not mine. So what you see here are huge defects in the ethmoid fovea, right? Huge defects. This is almost 1 centimeter both ways, 1.2 centimeters and then 1.8 centimeters in length, right? And what is coming into the ethmoid is the brain. Now, this is not inadvertent, is not, to me, not forgivable, because this means you've taken out a big piece of bone with a heavy instrument, either a debrider or a big forceps, and you've done it not one side, on both sides. So this patient came to me, and what is your straightforward answer? Boss, this cannot be done endoscopic. There's a septal perforation to add to it, so I don't have any hard flaps. You have to go transcranial. And he was accompanied by his ENT, and he said, we have been to 3 doctors, everybody tells us that. Patient refuses to go transcranial, you have to do it endoscopic. I said, it's not possible. He said, no, you try. So I said, okay, I'll try, but you have to give me consent to go transcranial if we need to do with the pericranial flap. Based on that, we went in and said, okay, we'll do this. So I'll show it to you briefly. Middle turbinate, and what you see in the middle meatus is all brain, okay? So this is not the ethmoid bulla. This is the patient's anterior cranial fossa coming in here. So first thing for me to do is to understand where I am. I don't know where I am in this area. So I have to, so you see part of the uncinate is still intact. Fortunately, middle turbinate was intact, ground lamella is intact, and yet this has gone in. So we have to find first the frontal sinus and the maxillary sinus so that I know where my landmarks are. I don't want iatrogenic sinusitis, so I want those sinuses to be open. So frontal sinus opened above, frontal supraorbital. Then we open the maxilla below it. So now I know where I am. I know the rest of it is now all ethmoid. So now we take a bipolar and we try and shrink this encephalocele. When we do that, there is no difference at all. It just doesn't shrink at all. It's just hard. So then I take a knife thinking maybe the outer part is hard and inner part is soft. Still no difference. Nothing moves. So I have no option but to take a debrider now and debride it away, because if I don't find that bony edge, I cannot do a repair. Right? So we are debriding. This brain is dead brain. It's not functional brain. I have a neurosurgeon with me in the theater whom I'm always talking to. Is this okay? Not okay? What am I doing? It's crazy what I'm doing, but am I okay to do it? So we're going to debride it, and then in between we keep bipolaring to see if now it's soft and will it shrink till it goes high enough towards the skull base, and then the last part we can bipolar. So once I've got towards that, I can try and then establish the bony edges. So we get the posterior bony edge, and we get all the bony edges. We take all the mucosa off from the lamina posteriorly and anteriorly, so that we have a bed for my flap or fascia to sit. Okay, big defect. Now I still want, with such a big defect, I want to use a flap. I am not happy doing a free repair. So I think, okay, let's try a flap, because that perforation is a little anterior. Even if it's a smaller flap, let's try a flap and see how it goes. So this is my bed now fully prepared. That's the perforation in the septum. And I start taking what we call a Haddad flap. So we start inferiorly with the incisions, and we come forward. All the way. And I have to stop at the level of that perforation. There's no point coming anterior to the perforation, because I cannot have a flap with a hole in it. So I stop there and go up, and then I complete the incision in the upper aspect. Now, my problem here to raise the flap is that both the septoplasty is done. So both the flaps are now stuck together. So I have to get a plane and separate these two flaps one from the other without any tears, either on the left or the right, because I need this flap on both sides. Right? So it does take a little bit of effort. You need that extra hand. You need somebody to just retract for you and open it up. But finally we do manage to get the flap separated. We also managed to get a small piece of cartilage, so that you can see how the two flaps are stuck together and how we are just separating it from each other. So once that's done, okay, then I want to rotate it, but it's not a big long flap, and my middle turbinate is now in my way. So in this situation now I have to sacrifice that middle turbinate, and I want to take it out intact. Again, I can use the mucoperiosteum of the middle turbinate as a repair material, so I'll keep it. The little bit of cartilage I got a strip, so I could use it just as a buttress, just to keep the brain from falling down. And then we put a little bit of fat on either side of that cartilage. And then I rotated that flap in, and fortunately for me, it sat perfectly. So it sat, covered the whole defect, but didn't block the maxilla, didn't block the frontal sinus. And then the same thing was done on the opposite side. So this surgery took us about 6 hours to do. And by God's grace, he healed well on both sides. We managed to save him the transcranial part. So if it's a small defect, and usually with an iatrogenic CSF leak, it's a small defect, you will just go fat or fascia. Very rare that you need cartilage. If by chance you have a big defect, then you want to swing a Haddad flap or any kind of flap in that area. Tissue glue can be used additionally, but it's not absolutely necessary. We go from there to nerves. These are your main nerves that come in your field: optic, V2, Vidian, and infraorbital palatine nerves if you're going transpterygoid. This is a patient who had been operated 3 times before for an antrocoronal polyp. He had again got a polyp. He was an orthopedic surgeon, and he said, boss, just be careful, I don't want anesthesia on my face. So I said, listen, all your polyp recurrence is anterior inferior. So I'm letting you know that there is a chance of that happening if you don't want a 5th surgery. This is now already your 4th surgery. So we are taking out that residual polyp from the anterior wall. Wasn't able to reach comfortably, so I came in from a small canine fossa and used a 120 debrider blade. And you see that's the infraorbital nerve, right? And just there where it forms one of the alveolar branches. We were taking the polyp out from close to it, and I managed to touch that alveolar branch. So that's how you can damage the infraorbital or its branches. And though this patient had 3 months of little paresthesia around the alveolus, he fortunately recovered. Okay, further back, if you are going towards pterygopalatine or you're going transpterygoid, transmaxillary, then you will enter the infratemporal fossa area, where you will see the sphenopalatine ganglion. If you were to cut that or open that up, you see these two nerves that everyone's familiar with, right? The Vidian nerve going into the pterygoid canal, V2 going into the rotundum, and V2 canal, okay? So this is your anatomy. This is the maxilla, this is the sphenoid, this is the medial pterygoid sitting here. So pterygo-sphenoid junction. You want to locate your Vidian nerve. It is at the junction of the pterygoid plate and the floor of the sphenoid sinus. So pterygoid plate, floor of sphenoid, Vidian nerve. Easy. Okay, so same thing here in a live surgery, CSF leak. You see we've drilled this whole area. So you have the Vidian nerve running across, and I have to go there to close this very lateral defect in a lateral sphenoid. So we do typically a transpterygoid, and you see above that is the Vidian canal, is the rotundum. So that's V2 running here. And when I open up the bone and expose the bone, that is my limit for V2. If I go higher than this, I'm damaging the V2 and the infraorbital, and I will have anesthesia of the face. Okay, so that's Vidian. In this situation, I will cut because I have no option to get to this encephalocele. I have no option. But that dryness of the eye stays for 2-3 months, and then it recovers. Okay, so finally, to just give you an idea of what we deal with in FESS, this is a very good dissection of the carotid that I actually did with SETI in Singapore. We've done a hemiclyvectomy, so you see at the back the pons, basilar, and the artery. You have the ICA, you'll have pontine branches, and then the basilar will divide. On this side, you see the carotid artery. Okay, so you have 3 movements of the carotid: inferior to superior, lateral to medial, most important, posterior to anterior. So your paraclival carotid is very posterior when compared to the paraclinoidal carotid. And it has the sharp angulation. It comes up, makes a very sharp turn to become the cavernous, which then forms a loop to become the paraclinoid. So this is the area that is usually close to the optic and can come in your way, or can be dehiscent, and you can have a problem. Lateral, of course, is the lateral cavernous, where you will have the 6th nerve joined with the 3rd, 4th, and V1 to go into the superior orbital fissure, which again is very close to your lateral OCR. Okay, post-op, what do you do if there's bleeding? You have to pack again if required. If it's an arterial bleed, please take the patient back to theatre, re-explore, and check bleeding clotting parameters. So if you had fat exposure, then this is what you will get: little bit of edema, little bit of ecchymosis, but patient recovers in 3-4 days. Don't blow the nose, sneeze, give some antibiotics. Adhesions and synechiae were a bane for us, and that lateralization of the middle turbinate was always a big issue until we started taking middle turbinate stitches. What we saw yesterday, one thing that we do a middle turbinate stitch, but we do not bulgarize. Okay, when you bulgarize, it means freshening the medial edge of the middle turbinate and the septum and getting them to stick together, right? Here I'm taking a stitch without bulgarizing, so when the stitch comes loose after 4 to 6 weeks, the middle turbinate can actually go back laterally and open up the olfactory cleft so that the patient's sense of smell is not affected. By which time the lateral wall is now healed. So even if the turbinate goes fully lateral, it doesn't matter. And this has saved us a lot of time in post-op care. It's just made post-op care a little painless and easy for the patient. With bulgarization, we were not happy at all. I mean, it was unpredictable, sometimes too much, sometimes too little, uneven, etc. Middle turbinate stitch you saw yesterday, we'll try and show you again with today. Crusting infection, of course, you give antibiotics. You can give T-Bact ointment with the wash nasal douche. Nasal douche being extremely important, I would say, for all patients with nasal surgery, except if you've done a CSF leak, to maintain the cavity and to help with healing. Ostium stenosis happens usually if you've done circumferential damage. So try and avoid that and try and keep mucosa on the edges of your bone. So we know this happens frequently with the frontal and the maxilla. What we don't know is what happens with the ethmoid. And the ethmoid has multiple septations. And when you do a very good ethmoidectomy, the ethmoid also collapses. And that tends to pull the middle turbinate laterally. So if I am sometimes doing a CRS, not polyp, not fungus, I may leave little partitions of the ethmoid behind, provided I can see the skull base clearly, just to act as a scaffold and prevent a collapse. Anosmia, if you've got polyposis patients, my limit is the inferior half of the superior and the middle turbinates. I will not go into the superior half because that's where your olfaction is. If you try and take polyps from that area, you will also permanently damage olfaction. So you stay in the inferior half and then you have to hope that medical treatment, since you've debulked everything else, is enough to clear those polyps. Osteitis and pain again is not common, but it happens if you've done too much mucosal damage and exposed a lot of bone, so you should try and prevent that. And when we talk of all of this, of course, to prevent equipment, and Sunil said yesterday that, get good equipment, not at the end of your, when you're a really good surgeon, because then you don't need the good equipment. You can manage with kitchen knives. But at the start, vision is paramount. Good instruments are paramount to be able to see clearly. If you can't see clearly, you can't do a good surgery. So you get good equipment, both in terms of optics and instruments. So I know this complication lecture can be a little scary, but it's not to dissuade the juniors, it's just to get them aware. You still have wondrous adventures in front of you, but unless you physically sail the seas, unless you actually encounter complications, you will not learn just listening to me or reading books. Important is to learn from your mistakes. Okay, thank you very much. I don't know if you have time for questions.